Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami. Welcome to our Monday afternoon Instagram chat. Today's topic is talking about fertility drugs, how they work, and when to use them. So the first very important concept to understand when we're talking about fertility drugs are that to call them fertility drugs is a little bit of a misnomer, because we use these drugs to help you get pregnant, and they've been referred to by patients and doctors for years as fertility drugs, but they're really not fertility drugs. The drugs are ovulatory drugs, and the drugs we're referring to come in two different varieties. There are oral medications and injectable medications. And the reason they were called fertility drugs is because they're stimulating the ovary to produce eggs, and hopefully that would result in a pregnancy. So what are they? They're ovulatory drugs. The oral ones are either Clomid or Femara. Femara also goes under the name of Letrozole. And these historically were used for patients who didn't ovulate at all, who didn't get periods, to take for 5 days in a cycle. And in that cycle of treatment, if they responded appropriately to the medication, they would ovulate, and you'd have a chance to get pregnant and be fertile in that cycle, basically. And Clomid has been used for many, many years, over 30 years, probably close to 50 years at this point. And it's used for 5 days in the month. And over the last 20 years or so, the alternative medication called Femara or Letrozole, which is a medication that was really devised as what's called an estrogen aromatase inhibitor to minimize estrogen levels in patients treated with breast cancer. That medication also does a good job at causing ovulation, particularly in polycystic ovary patients. So the use of the oral fertility drugs, Clomid and Letrozole, are the first-line treatments in patients who don't ovulate at all. And these are usually done by first doing an ultrasound at the very beginning of the cycle to make sure that the ovary doesn't have any cysts in it, and then using the medications for 5 days, either days 3 through 7 or 4 through 8 or 5 through 9. Occasionally we can have other variations, and we usually have the patient use an ovulation test kit, and then in the middle of the cycle use ovulation kits to see if they're ovulating. And we usually bring them back on the 13th day of the cycle to do an ultrasound and some blood tests to ensure that they're responding appropriately to the medication. We want to make sure that you're producing eggs. You can't see the eggs, but you can see the lake of fluid that the egg sits in, called the follicle. And the hormones tell us that you're producing a reasonable amount of hormone. We also make sure that the lining of the uterus has developed properly, so that if the egg does fertilize and is transported back to the uterus by the tube, it has a good chance of implanting and sticking, resulting in a baby. In patients who ovulate on their own, or who have a male factor where the sperm might not act normally, we very commonly use these oral ovulatory drugs in combination with intrauterine insemination. And that's just when we're trying to fine-tune the system, basically. We're trying to optimize ovulation from occurring. Occasionally we'll get 2 instead of 1 egg to ovulate. And by knowing when ovulation is actually taking place, by us giving you HCG to trigger ovulation in the middle of the cycle, we can time inseminations at an appropriate time frame and maximize our chance of the cycle working. So we have the oral medications being used historically for people who just don't ovulate, and then we have it used for people who do ovulate but don't ovulate 100% normally, or who we need to figure out the best timing of doing insemination in cases of male factor, or even unexplained infertility. The second type of fertility drug or ovulatory agent are what are called injectable gonadotropins. And the trade names of these are in the form of recombinant FSH. We have Gonal-F and Follistim, which is FSH, follicle stimulating hormone, and Menopur. Menopur is a combination of FSH and LH, or follicle stimulating hormone and luteinizing hormone. And it's the FSH component mostly that's responsible for the stimulation of the ovary and the development of the follicle with the egg inside, so you have a good quality egg. Now, when are injectable medications utilized? If you have somebody who doesn't respond to the oral medications, let's say if someone doesn't ovulate, you try Femara or Clomid, they don't respond, you increase the dose. They don't respond, you can increase the dose. If you reach a maximum dose of these oral medications and you're not responding to them, then we have to go to an injectable form. And in some patients that have a partial response, we can actually blend the two, and that's called the mini-stim approach, where we're using the oral medications for 5 days and then adding very low doses of the injectable medications afterwards. In patients who don't ovulate properly and don't respond to oral medication, then we use injectable medications. The injectables directly stimulate the ovary, so it's a much stronger stimulation to the ovary. And depending on what our goal is, we'll address how much response is okay. Now, if you have somebody who doesn't ovulate properly, the best response we can get is 1 or 2 eggs to ovulate. If you have somebody who's not getting pregnant with Clomid, but they're ovulating on Clomid, but they're just not getting pregnant, then ideally we'd like 2 or 3 eggs to ovulate rather than just 1. But the downside of that is you increase the risk of multiple pregnancy, but the upside is you get a better chance of getting pregnant because more eggs are getting out. So we tend, in patients who don't ovulate properly, use very low doses of these injectable fertility drugs. And they're mostly used for patients that either don't respond to Clomid or Femara, who are anovulatory patients, or they're used in patients with unexplained infertility who don't get pregnant with Clomid and intrauterine insemination. And more commonly, they're used in preparation of the ovary for in vitro fertilization. And when you're using these injectable fertility drugs, these gonadotropins, you have to ask the question first is, what is our goal at the end of the day? If we're going to be inseminating you and we're trying to recreate ovulation that's not occurring on its own, our goal is to get 1 to 3 eggs to ovulate. However, if we're doing IVF, the plan is going to be to take the eggs out of the ovary, fertilize them in the dish, and then transfer the embryos back into the uterus, then ideally we prefer 15 or 20 eggs, particularly if we're doing fertility preservation in somebody who's freezing their eggs now so that they can maintain their fertility when they want to get pregnant down the road. And we see this more and more commonly, and we should see it more and more commonly in patients who are in their early 30s that are not in a relationship, they're not trying to get pregnant now, they're not thinking of having a child, and they want to go, hey, if I want a baby 15 years from now or 10 years from now, how do I preserve that from happening? And anybody in their 30s is a candidate for egg freezing. Earlier is better than older in age because you get more eggs, but in general, as long as you have ovarian reserve and will respond to fertility drugs, having some eggs frozen is better than not having any. So with the injectable medications, what's done is an ultrasound is done at baseline when you get your period, the same as with the Clomid or the Femara. We start out with a dose of medication that we think you're going to respond to. And here, again, it's a matter of what's our game plan. If our goal is to recreate normal ovulation with just a limited number of eggs, then we usually will start out with a low dose of medication, unless we have indications from prior records that you're going to be more resistant to the medication, in which case we'll be a little more aggressive with it. With IVF, where we definitely want multiple eggs to develop, we'll start out with a higher dose of medication, and that dose is selected by a combination of age, weight, past experience, AMH level, antral follicle count, FSH level. So all those things are kind of thrown in the cooker together, and we take all that together, and with our best judgment, we'll make a recommendation on what we feel is the most optimal dose to get you the most optimal response. How successful are these medications? If we look at patients that don't ovulate at all and we recreate ovulation with an oral agent like Clomid, what you're going to see in women that are under the age of 40 is about 18% pregnancy rate per cycle, which is a normal age-related fecundity rate. This is the same it would be as if you were ovulating normal, just threw away the birth control pill and said, let's get pregnant. In patients over age 40, it's going to be half that amount. Now that's different than if you use these medications with insemination to treat unexplained infertility or mild male factor or a mild ovulatory disorder, where we know we're not fixing the only thing that's broke. Here we have a system where there may be multiple little things there, and by fine-tuning ovulation, you're not going to fix the sperm. You may help get them to the right neighborhood where the egg lives by insemination, but you're not going to totally correct the sperm. So when you look at success rates of Clomid with insemination, you only see success rates of around 8% per cycle, and in women older 40, less than that. If the sperm is significantly compromised, then you're going to see even lower rates, and you have to really wonder whether this is the best way to get pregnant or not. Now, with unexplained infertility, unexplained infertility being a situation where you ovulate normally, the sperm is normal, the tubes are open, the ovarian reserve is acceptable, you're just not getting pregnant, and we don't really know why. You can treat that even though we don't know why you're not getting pregnant easily, and the first line treatment is to consider a fertility drug with insemination. And if you do that with Clomid and insemination, you see the same low, less than 10%, about 8% per cycle success rates. But if you use injectable fertility drugs with inseminations in women that are under age 40, we'll get more of an 18 to 20% success rate, and in women 40 years old, about half that. So you get much better success rates using injectables, but injectables are more expensive. They require more monitoring. They are associated with multiple births more frequently and have a higher risk of ovarian hyperstimulation syndrome, which is the major serious concern when using injectable medication. So we usually will tend to go oral medications first. Occasionally we'll blend the two together, particularly the blend tends to get 2 or 3 eggs out and make sure that the eggs are developing, but we'll tend to have less likelihood of developing hyperstimulation syndrome and a lower high multiple birth incidence associated with it. And then we would use injectable medications along with insemination if we have to for IUI and unexplained infertility. Most patients, by the time they get to that point, if we're treating unexplained infertility, feel a lot more comfortable. It makes a lot more sense to just go directly to IVF, where we could have a potentially 50% pregnancy rate if we have a normal embryo to transfer into a normal uterus. Side effects of these medications, the oral medications, Clomid, most of the time none. Sometimes you get a little moodiness, a little irritability. Sometimes you can have hot flashes for a couple of days when you're taking these medications. Multiple birth risk with Clomid is 8%. The risk of triplets is only 1 in 1,000, and most patients do very well with it. Hyperstimulation syndrome, where the ovary swells up like a big grapefruit and you can retain fluid and potentially even need to be hospitalized, is very rare with the oral medications and much more at risk if we're using injectable medications. The injectable medications you don't tend to get the hot flashes with because it's not an anti-estrogenic drug. But you do get some moodiness and irritability from the high doses of the hormones that result, not from the medication itself. Allergic reactions are very rare. The biggest concern is too much of a response. Too much of a response means if we're trying to do insemination or just recreate ovulation to have relations in a patient who didn't respond to Clomid, in that group, anything more than 3 eggs developing, we would recommend canceling a cycle. However, if we're doing IVF, then having lots of eggs is great. With that, we then modify. When you do IVF, you're seeing the patient much more frequently, having many more ultrasounds and blood tests, and we're adjusting the medications over a 9 or 10 day period to try and reach that sweet spot of 15 or 20 eggs if we can, and at the same time minimize the risk of hyperstimulation. You do that by decreasing the amount of fertility drug, potentially changing the medication we're giving somebody in the middle of the cycle. Instead of HCG to trigger the release of the eggs, we can use Lupron in most cases. And if we want to prevent it even further, we can consider using cabergoline, which is an oral medication to be used after HCG trigger for a week to try and minimize things. And that's pretty much the whole story of fertility drugs. The use of them is pretty ubiquitous. We use fertility drugs on most of our patients in helping us treat patients, whether it be with a combination of an ovulatory drug with insemination, whether it's to restore ovulation, or whether it's in preparation for IVF to produce as many eggs as we can, as well as for egg freezing and fertility preservation. That's the whole story. We ask you to ask us questions as you come in. Ovarian hyperstimulation, someone asked a question. Ovarian hyperstimulation occurs sort of the perfect storm. You have to have a very high estrogen level, a production of lots of follicles, and the release of some substance into the abdominal cavity, and the presence of HCG. And so we try and minimize that risk by changing one of those things. Obviously, if we want lots of eggs, the thing we try and change is the trigger for the release of the eggs, and that most often results in minimizing the risk of hyperstimulation. Question was, in freeze-all cycles, use progesterone to prevent ovulation instead of cetrotide. We don't like using progesterone in the first part of the cycle. It's not normally there, so it doesn't make any sense to have it there. You can use progesterone in a freeze-all cycle in the second half just to let ovulation come down. But we wouldn't use progesterone to prevent ovulation. We would use cetrotide or the organorelix, which is the other antagonist. So thank you for tuning in today. If you have any additional questions, let us know. Again, just brief summary. The oral medications, Clomid, Femara, work well for their indication. The injectable medications produce more eggs, tend to be more successful, and are absolutely necessary if we're doing IVF, where that is our goal. So have a good afternoon. Stay safe. Bye. Okay.